I would say that developing effective communication skills is one of those things that everyone talks about. Um, Sometimes people may think that maybe it's not quite attainable, but when we do trainings on these communication skills, people come into these trainings, sometimes they're full-day trainings. People come into the trainings seeming a little skeptical, and they come out of these trainings with the sense of renewal. We were talking earlier about how providers kind of have better satisfaction of their jobs. There's a sense of renewal because they're not only connecting with patients better, but they're also connecting with what brought them into medicine in the very first place. They remember that they're here in order to help others and heal others. And that's one of the things that's so inspiring about this work, is that better communication skills training gives us a sense that we're accomplishing our mission. The way I think about them are tools at the beginning, tools in the middle, tools in the end, and then there's the special tools that you need to use every so often. So the tools at the beginning, as you may have seen in the video, the first one is just the plain old introduction, using your full name, coming in with authentic delight at seeing the patient. The second thing is to decrease the space between the patient and the provider. And one way of doing that is to go into the patient's space first. That is to say, so I would go into the patient's room and I said, I'm sorry to interfere with your reading, for example. In the outpatient setting, it's how is it that you got here? So in the first, and that's all taking place in the first 10 or 15 seconds of the interview, basically. And the research shows that if you get all of the patient's concerns out of the very beginning, you're less likely to get a doorknob question at the very end, which is one of the things that really hassles providers, is they hate to hear that, oh, by the way, I've got chest pain at the very end of the interview, because they've done all of their work and they think they're done, moving on to the next patient in a time-limited setting. All of a sudden they have to do something else. So by doing the elicitation all up front, then that makes them more efficient, and that's a good thing. And then the final thing there in the very beginning is to set the agenda for the visit. And that is to say, so these are the things that you want to talk about. I want to talk about these things. How about if you pick 2 of the 4 things that you want to talk about, I'll pick 1 of the 2 things that we can talk about. We've got these 3 items to accomplish for today, and that's about all that anybody can really hold on to, to take home or to sit in the hospital with. In terms of cognitive load, there's only so much that you can do in a visit. Then we move on to the middle of the interview, and typically what providers do in the middle of the interview is they focus in on their thinking, their cognitive processing, the clinical reasoning part of things, because that's what we're trained to do. And what I try to do is just to take a moment, again, to let the patient in before I go to what I need to do. So there's the patient-centered side of the beginning of the middle of the interview, and then there's the doctor side. And the patient-centered side is to ask about the patient's perspective of illness, specifically talking about what feelings the patient has about what's going on with them, what ideas they might have, how it might affect the function, and then what expectations they may have from their interview. And the other thing is statements of empathy. It sounds concerning to you. I want to work with you on this. Most people would feel that way. I'm really glad you told me about these things. So it has been shown that in both surgical and medical settings, that presence of an empathic statement decreases the length of the visit. Most patients who come into their visits have some emotion, some usually negative emotion about what's going on with them. They're afraid of what might be happening. They're scared of the consequences of it. They're angry at the care that they've had before. And if the provider doesn't specifically and explicitly address those emotions empathically, then either the patient gives up, which is the worst outcome, or finally the provider clues in, oh, the patient is saying scared, frightened. I'm hearing this several different times. So better to have those empathic statements closer up front, so that will make the patient feel like they're not talking to a brick wall. They won't keep on reiterating, and that's what makes the visit shorter. So those are the important pieces of the middle of the visit, with the caveat that empathy goes throughout. Rather than just being a soliloquy from the doctor, a one-way download, what we're trying to encourage providers to think about instead is more of a dialogue involving what we call the ARTs. So ask, respond, tell, and then seek solutions. It turns out that the mnemonic is great for many different reasons, but for the purposes of the end of the visit, it's useful to engage the patient at the very end into the plan. And that carries through to the very end, which is, I think for me, the most important part of the closing, which is the teach back. And the teach back is summarizing the entire visit. I used to do that summary myself. And what I found over time is that if the patient does the summarizing for me, then they're more likely to do those things that we talked about in the visit. So these are kind of life skills, even much more so than patient-provider skills. And the patient-provider skills taught me these things.